we talked about prostaglandins in the previous session, and just like I said, whenever we are studying non-steroidal anti-inflammatory drugs, we should always first study prostaglandins, because non-steroidal anti-inflammatory drugs, they act by inhibiting the synthesis of prostaglandins. And so the all pharmacological actions of prostaglandins, they are inhibited by non-steroidal anti-inflammatory drugs. And we need not to study them separately. So we have talked about the effects of prostaglandins on various systems. We talked about what is the effect on cardiovascular system. They cause vasodilatation. What is the effect on platelets? This causes thromboxane, causes adhesion and vasoconstriction. Prostacyclins or PGI2, it causes vasodilatation and inhibition of platelet aggregation. Like in the kidney, the blood supply is increased, there is diuresis, increased renin. The effect on lungs is bronchoconstriction. In the eyes, we talked about uses of prostaglandins also. They are used in glaucoma, open angle glaucoma, because they increase uveoscleral flow. So we have talked about all those effects of prostaglandins, how the fever is produced. Now we come to non-steroidal anti-inflammatory drugs. Remember, willow bark had been used for a very long time as a painkiller, as antipyretic, but the active principle was not known, and this was known in 1970s. We talked about in the video on prostaglandins, we talked about the Nobel Prize that was given to Wayne, Samuelson and Birdstorm in 1982. That is because of the work they have done on NSAIDs. That is, they came to know that this causes inhibition of prostaglandin synthesis. And what is the simplest NSAID that we have, or the first NSAID that we have? That was aspirin, salicylic acid, and it was acetyl salicylic acid. So if we see salicylic acid, it is very simple structure. This is salicylic acid, and when we add here, it becomes acetyl salicylic acid. Very simple structure, but inhibits prostaglandins. So we won't go in details of that. We have talked in detail about how prostaglandins are synthesized, and there are two pathways from arachidonic acid. One pathway is cyclooxygenase, another pathway is lipoxygenase. Cyclooxygenase pathway causes synthesis of initially PGH2, PGG2, PGH2, and then PGE2, D2, I2, F2 alpha, thromboxane A2, that is through cyclooxygenase. And in lipoxygenase, there is synthesis of initially 5-hydroperoxyicosate tetraenoic acid, that is converted into leukotriene B4 C4. Leukotriene C4 is then converted into D4, E4 and even F4. They are known as slow reactive substances of anaphylaxis. So this NSAID or aspirin, this causes inhibition of cyclooxygenase pathway. Remember, inhibition of cyclooxygenase only. There is no is inhibited. Lipoxygenase is not inhibited. And so there is decrease in the synthesis of these compounds. PGG2, H2, D2, I2, F2 alpha, thromboxane, they are inhibited. There is no effect on synthesis of leukotrienes. We should remember this. So which are the drugs that we have? Remember this also cyclooxygenase. We should remember cyclooxygenase is found in two forms. One is COX-1, another is COX-2. COX-1 is found in the constitutive form, we call it. Means this is present and functions as a part of the body for maintaining homeostasis or for normal functioning of the body. The COX-2 is, we call it inducible. Means whenever, because of any reason, say inflammation, it is induced, means synthesis is induced, and then only in those places this is produced. So COX-1, it is present normally. In some places, COX-2 can be present constitutively also, like we always say in the kidney it is present. Sometimes we say in the lungs also it is present. So that may be there, but broadly we have to remember COX-1 is present constitutively for maintenance of normal wear and tear of the body. COX-2 is inducible whenever required by inflammation or some other stimulants. This can be produced. Why it is important to remember? Because there was a drive before 10 years. A lot of COX-2 selective inhibitors were found out, because this was found that they will have lesser side effects. Remember, non-steroidal anti-inflammatory drugs, they have a large number of side effects, because we have talked about pharmacological actions of prostaglandins. All those effects are inhibited. So prostaglandins, as we said, they are most widespread autocoids in the body. So when they are inhibited, there are generalized effect on the body. So it was thought that if we can have selective COX-2 inhibitors, then we can only inhibit inflammation and rest of the functions of the body will be normal. But later on it was found out that they were very cardiotoxic drugs, but they were discovered and even now they are used. Preferential COX-2 inhibitors are nimesulide, diclofenac, aceclofenac, meloxicam and etodolac. And selective COX-2 inhibitors, they are coxibs, celecoxib, etoricoxib and pericoxib. They are selective. And these drugs, they are said to have poor anti-inflammatory activity, good analgesic antipyretic like paracetamol, aminophenol derivative, or nefopam. They are said to be having less anti-inflammatory activity. And non-selective COX inhibitors which are traditionally present: salicylates, aspirin. Aspirin is salicylic acid. Propionic acid derivatives are ibuprofen, naproxen, ketoprofen, flurbiprofen. Phenamates are mefenamic acid. Enolic acid derivatives are piroxicam, tenoxicam. Acetic acid derivatives: ketorolac, indomethacin, nebumetone. And pyrazolone derivatives are phenylbutazone, oxyphenbutazone, propyphenazone. We have to mug it up. Remember, non-steroidal anti-inflammatory drugs is one topic in undergraduate syllabus that we find very easy. But whenever we are asked questions, we are unable to describe the things. We just answer in one line. If somebody asks, enumerate non-steroidal anti-inflammatory drugs. We just say aspirin, diclofenac, brufen, this, that, 3-4 drugs. We have to remember like this: which are non-selective, which are preferentially COX inhibitors, which are selective COX inhibitors, and which are having less or poor anti-inflammatory property. Amongst non-selective, we have to remember these chemical structure like salicylates, propionic acid derivatives, phenamates, enolic acid derivatives, acetic acid derivatives, pyrazolone derivatives. This is how we have to remember. There is no excuse. Most commonly used drugs by MBBS are NSAIDs. We will talk about their adverse effects first. We have talked about pharmacological actions when we talked about prostaglandins. All the actions of prostaglandins are inhibited, and when they are inhibited, then what will happen? Either there will be some useful effect or there will be some side effect. So we'll talk about adverse effects first, uses we'll talk later. Metabolic and other effects. Remember, cellular metabolism is enhanced due to uncoupling of oxidative phosphorylation by NSAIDs. This I have taken in the beginning, though in the books it is given in the end. I want, because rest of the effects can be explained by remembering prostaglandins, pharmacological actions. This is unique. So this oxidative phosphorylation is inhibited. Because of that, what happens? Glucose utilization is increased. In diabetics, they may cause hypoglycemia. Remember, in many cases, we say in cases of poisoning, there is hyperglycemia also. That is because of stimulation of sympathetic system, because of NSAIDs. Why that happens? Because of shock conditions. But initially, there will be hypoglycemia. And because uncoupling of oxidative phosphorylation has taken place, there is a lot of wastage of energy. This is how, what happens? There is increased CO2 production. And when there is increased CO2 production, the respiratory center will be stimulated. NSAIDs, remember, directly also they stimulate respiratory center and through CO2 production also. So respiratory center is stimulated. When respiratory center is stimulated, there will be tachypnea. When there is tachypnea, there will be carbon dioxide washout, we call it. And that causes alkalosis. Remember, whenever carbon dioxide in the blood increases, this causes acidosis. When there is the carbon dioxide from the blood is depleted, then there is alkalosis. And what body will do to maintain the normal pH? This will cause excretion of bicarbonates in the urine, because this wants to take care of this alkalosis. So this will excrete bicarbonates. So this is what we say compensated respiratory alkalosis. Alkalosis is there, but that is compensated by bicarbonates. But if we are taking for a long time, what will happen? Or we suppose we are taking large doses, anti-inflammatory doses. Normal doses, there may not be any problem, antipyretic doses of aspirin. But when we take drug doses like 5 to 7 gram per day, that is what we say anti-inflammatory dose, or 100 milligram per kg, then what happens? If we are using it for a very long time, what will happen? Bicarbonate will be depleted, because this has been utilized for maintaining, for compensating alkalosis. And if I further increase the dose, then what will happen? Respiratory center is depressed. Remember, respiratory center is depressed, but carbon dioxide production is not. So what will happen? There will be accumulation of carbon dioxide, and this will cause acidosis. And now this time, this will cause also increased production of lactic acid, pyruvic acid, acetic acid also. So this is known as uncompensated metabolic acidosis. Uncompensated metabolic acidosis, this is known as. So remember, with NSAIDs, if we are using very high doses, or in children, initially there is respiratory alkalosis, that is compensated. So we call it compensated respiratory alkalosis. That is, if it continues, then in the end we get uncompensated metabolic acidosis. What are the effects on GIT? We talked in case of prostaglandins, that prostaglandins are gastroprotective. They protect the mucosa. So if we are giving NSAIDs, what will happen? Most common adverse effect. What is that? Gastric irritation, dyspepsia, epigastric pain, nausea and vomiting, heartburn, peptic ulceration, gastric as well as duodenal, both, because there is increased production of acid and there is no protection to mucosa. The prostaglandin prostaglandins, they were protective. We have stopped production of those prostaglandins. So occult blood loss leading to iron deficiency anemia, hematemesis or melena, increased risk in elderly patients and those receiving corticosteroids or anticoagulants. Remember, it is said that this occult blood loss is there. We don't come to know about it. Whenever we take NSAIDs, there is some blood loss in the GIT. Mechanism: inhibition of gastric PGE2 and PGI2. Reduces mucus and bicarbonate secretion. Decreases mucosal blood flow and impairs mucosal repair. All these are mechanism for this. Renal adverse effects. We talked in case of prostaglandins that they increase blood flow to the kidneys, they cause diuresis-like effect. Here, salt and water retention. Opposite to that, peripheral edema, reduced glomerular filtration rate and acute kidney injury. Electrolyte disturbances is hyperkalemia. Chronic effects: analgesic nephropathy, chronic interstitial nephritis, papillary necrosis, especially with prolonged abuse. Clinical consequences are worsening of hypertension, precipitation of heart failure. Mechanism: we know PGE2 and I2, they were responsible for increased blood supply to the kidneys. Now that is stopped. So that is the reason. Cardiovascular adverse effects are increased blood pressure. We know because of kidney also, but this is also direct. Fluid retention and edema. Exacerbation of congestive heart failure, increased risk of myocardial infarction, increased risk of stroke, especially associated with selective COX-2 inhibitors. Mechanism: reduced endothelial PGI2 without suppression of platelet. What happens? Reduced endothelial, remember there is a balance between PGI2 and thromboxane. So these COX-2 selective inhibitors, it was found that they inhibit only PGI2. The production of thromboxane is not affected. And that is one of the reasons for having prothrombotic state in the body. Hematological effects: impaired platelet function, that we all know, prolonged bleeding time, increased peri-operative bleeding. Why this happens? Aspirin specific effects: irreversible inhibition of platelets aggregation. Remember acetyl salicylic acid, when we say in low doses, so actually antiplatelet effect occurs even before this drug reaches the liver. In the portal circulation only, this acetyl salicylic acid acetylates the serine residue in of the thromboxane, and because of that thromboxane does not work. If we give higher doses, then even prostacyclin is inhibited. That is why we say low dose. Second important thing is that in high doses, if you completely block cyclooxygenase, then most of this arachidonic acid is shifted to lipoxygenase. Lipoxygenase are they have their own cardiovascular effects. We talked about that in the previous lecture. B4, C4, D4, they are slow reactive substances of anaphylaxis. So in low doses, and why only aspirin? Because this is irreversible inhibitor. This causes irreversible acetylation of thromboxane. Other drugs, remember, one or two more drugs are found to be having antiplatelet effect, but that is very less compared to, and that is because it is reversible. After some time the effect goes. So here it is completely blocked thromboxane, so the effect lasts for 7 to 10 days because the new platelet has to be generated. Remember, platelet does not have nucleus, so it cannot produce its own new thromboxane. So the new platelet will come that has thromboxane in it. That is the concept of having 7 to 8 days duration of action. This is the life of platelet. So the platelet in which thromboxane has been inhibited, it will be metabolized, it will be destroyed, new platelet will come after 7 to 10 days. Hypersensitivity reactions, skin rashes, urticaria, angioedema, rhinitis, bronchospasm, anaphylactoid reactions. Remember, we don't consider it very important, but this can be very problematic. The way these drugs are used by everybody, the incidence may be very high of these reactions. Aspirin-induced asthma, characterized by asthma, nasal polyps and rhinitis. Mechanism: shunting of arachidonic acid metabolism towards leukotriene synthesis. That is the reason. Hepatic adverse effects: elevation of liver enzymes, hepatitis, cholestatic jaundice, hepatic failure, very rare. More commonly reported with nimesulide and diclofenac, and in children. Nimesulide is not used in children. Central nervous system effects: headache, dizziness, vertigo, drowsiness, tinnitus. Remember, these drugs, they do not cross blood-brain barrier very easily. They do cross placenta. They do not cross blood-brain barrier, and they have a unique characteristic. Remember, acetyl salicylic acid, we talked about that it is slightly acidic in nature, but it should be very fast absorbed from the GIT, from the stomach, but it is not water soluble, not much water soluble. It becomes more water soluble at alkaline pH, but at alkaline pH it gets ionized. And another important thing is that when we give aspirin, this gets absorbed, but in the cells the pH is 7.4 or 7.6, so there it gets ionized. So absorbed from the stomach where the pH was acidic, but in the cell the pH is basic, and so it gets trapped. That is known as aspirin trapping, ion trapping. That is another reason why there are so many cases of ulcer that is seen. So that is about absorption. Half-life is different. As I said, in case of analgesic, antipyretic, the half-life is different. As antiplatelet, the half-life is very long. So around 70 to 80%, sometimes more protein bound, plasma protein bound, and because of that we always talk of drug interactions with warfarin, with phenylbutazone, with these drugs. So this displaces them. Otherwise it has good volume of distribution, something around 1.7 liter per kg. So volume of distribution is good, but does not cross blood-brain barrier so easily. But in salicylism is a side effect of this NSAID, and that is basically tinnitus. There are sounds in the ear, that is salicylism, we call it. Confusion, especially in elderly patients, and if we give very high doses. So these are seen. Pregnancy and fetal effects, maternal effects, prolonged labor due to inhibition of uterine contractions. We talked about that in prostaglandins, they cause uterine contractions. Increased bleeding tendency. Fetal effects, premature closure of ductus arteriosus, persistent pulmonary hypertension of the newborn, oligohydramnios due to fetal renal dysfunction. NSAIDs should generally be avoided during the third trimester. So we have to remember, during delivery we should not use it because of antiplatelet action. Miscellaneous effects, photosensitivity reactions, they are quite common. Aseptic meningitis, rare, particularly with ibuprofen. Stevens-Johnson syndrome and toxic epidermal necrolysis, though rare, but these are also side effects. What are the uses? Again it comes, whenever we ask about side effects, what we say, this causes gastric ulceration, and then we keep quiet. So we have enumerated so many adverse effects. Now therapeutic uses, where is it used? It is used in inflammation. It is used in fever, that's all. We have to remember in detail. As I said, this is a very simple topic and very commonly asked topic. What are the uses? Analgesic in mild to moderate pain. NSAIDs are effective in pain associated with inflammation and tissue injury. Compare it with opioids. And as anti-inflammatory, we have to compare it with corticosteroids. So it is used in inflammation and tissue injury. Opioids are not effective in these conditions. Common indications: headache, migraine, dental pain, musculoskeletal pain, low backache, myalgia, post-operative pain, soft tissue injuries, cancer pain as adjuvant. Drug examples are ibuprofen, diclofenac, naproxen, ketorolac, aceclofenac. Actually any can be used, but as anti-inflammatory we don't use aspirin. That we should remember. But here as analgesic we can use aspirin also. Antipyretic, NSAIDs reduce fever by inhibiting prostaglandin synthesis in hypothalamus. Indications: fever due to infections, fever associated with inflammatory disorders. Drug examples are aspirin, rarely used in children. Rage syndrome is observed. Ibuprofen, diclofenac, paracetamol, antipyretic but poor anti-inflammatory action. In classification also we have talked about it. Anti-inflammatory used in disease characterized by pain, swelling and inflammation. Rheumatological disorders are rheumatoid arthritis, osteoarthritis, juvenile idiopathic arthritis, ankylosing spondylitis. Other inflammatory conditions are acute gouty arthritis, bursitis, tendinitis, synovitis. Drug examples are naproxen, diclofenac, indomethacin, piroxicam, meloxicam, celecoxib, and not only this, coxibs. All they were COX-2 selective inhibitors. They were meant for only anti-inflammatory. Dysmenorrhea, NSAIDs are drugs of choice for primary dysmenorrhea. Mechanism: inhibit endometrial prostaglandin synthesis, reduce uterine contractions and ischemia. Prostaglandins, they decrease, they causes contraction in the uterus, so they inhibit that contraction. Drugs used are mefenamic acid, ibuprofen, naproxen, diclofenac. Mefenamic acid is more commonly used in dysmenorrhea. Antiplatelet use: aspirin, irreversible inhibitor of platelet COX-1, suppresses thromboxane A2 formation. Clinical uses: secondary prevention of myocardial infarction, prevention of ischemic stroke and transient ischemic attacks, prevention of stent thrombosis, chronic coronary artery disease. So all these are indications of aspirin. Closure of patent ductus arteriosus. Drug is indomethacin or ibuprofen. In case of prostaglandins, we talked about, if we want to maintain patent ductus arteriosus, then we use prostaglandins. But here we are using indomethacin and ibuprofen for closure. Inhibit prostaglandin synthesis, responsible for maintaining ductal patency. Prostaglandins, they maintain the ductus arteriosus. So we give indomethacin or ibuprofen if it closes prematurely. Colorectal cancer, chemo prevention. Aspirin and some COX-2 inhibitors reduce recurrence of adenomatous polyps, may decrease the risk of colorectal carcinoma in selected high-risk individuals. This is one of the indications. Prevention of preeclampsia. Remember, 80 to 100 milligram per day from 12th weeks till childbirth in high-risk cases. It can be used prophylactically in high-risk cases. Mechanism, basically preeclampsia is believed that it is because of imbalance between thromboxane A2 and PGI2. So by giving this imbalance is maintained. So these are the uses of NSAIDs.